Imagine looking through a perfectly clear window, seeing everything outside, sharp, vibrant. Now, picture that window slowly getting frosted over, blurring the view, dimming the light. Or think about a hidden drain inside that window frame, crucial for managing pressure, but it slowly, silently clogs up. You don't see it happening, but the pressure builds, damaging the delicate structures behind it.
Right, affecting the whole system.
Welcome to the deep dive. Today we're exploring that intricate machine, the human eye, focusing on what happens when two key parts, that clear lens and the vital internal drainage system, start to fail. We're talking cataract and glaucoma.
Two major causes of vision loss, absolutely.
And this isn't just a surface skim. We're basing this deep dive on detailed excerpts from a specific medical text, focusing only on these conditions. Our mission today, because you asked us to, is to go incredibly deep into this material. We're pulling out every single important detail, fact, concept within these pages.
Yeah, the goal is really understanding this source material at the level of the elite professionals in the field.
Exactly. Think of this as your shortcut to truly mastering this specific source. Okay, let's unpack this, starting with the lens. What is this structure?
So the lens, it's really quite unique. Structurally, the source describes it as biconvex, like two curved surfaces meeting back to back.
Okay.
Its diameter is about 8.8 to 9.2 millimeters. And its thickness, front to back, actually changes. It gets thicker when we accommodate, focus up close.
Like when reading something.
Precisely. And the curves aren't the same. The front, the anterior surface is flatter, about a 10 millimeter radius. The back, the posterior, is steeper, around 6 millimeters. And when we accommodate, that front surface actually gets more curved, its radius shortens.
Interesting. And its main job?
It transmits and refracts light. About 80% of visible light gets through,
Yep.
and it provides about 35% of the eye's total focusing power. The cornea does most of the initial bending, but the lens handles the fine-tuning.
And you said it keeps growing. That's unusual.
It really is. It produces new cells continuously throughout life. Starts around 65 milligrams at birth, can get up to maybe 258 milligrams by age 80. This continuous growth is pretty significant, as we'll see.
How does it stay put in the eye?
It's held by these tiny thread-like things called zonules. They attach to the lens capsule, mostly around the front and the equator, and connect it to the ciliary body, which is a muscle structure just behind the iris.
Okay, let's go inside the lens. What's the structure like?
Well, fundamentally, it's all epithelial tissue enclosed in a capsule. That capsule is a thick, clear, collagenous basement membrane.
Made by the lens cells themselves.
Exactly. Secreted by the epithelium, it acts like a regulator controlling transport. It's actually thickest near the front edge and thinnest right at the very back pole.
And the epithelium.
It's just a single layer of cells lining the inside of that capsule. There's a central area where the cells aren't really dividing, and then a zone near the equator, the pre-equatorial zone, where cells are dividing. These are the cells that give rise to the lens fibers. And these epithelial cells are linked by gap junctions and desmosomes, allowing them to communicate and share nutrients. Interestingly, the source notes they don't have tight junctions, unlike many other epithelia.
So those dividing cells become the lens fibers. How do they achieve that incredible clarity?
It's quite a process. These pre-equatorial cells divide, then they elongate and differentiate. And here's the crucial part for transparency. They undergo pinosis, losing their internal organelles, including the nucleus.
So nothing inside to scatter the light.
Precisely. The new fibers form on the outside, pushing the older organelle-free fibers deeper towards the center. So the youngest fibers are just under the capsule, the oldest are deep in the core.
What are these fibers made of?
Mostly protein. About 90% of their mass is crystalline-specific types called alpha, beta, and gamma.
And within the lens, we talk about cortex and nucleus.
Yes. The outer part is the cortex, the inner part is the nucleus. The nucleus contains the very earliest fibers, the embryonic and fetal nucleus. Clinically, when we see that yellowish, dense central part on a slit lamp exam, that's what we mean by nucleus, though it includes some deep cortex too.
Okay.
The nucleus fibers are packed incredibly densely, giving it a higher refractive index than the cortex.
I recall seeing diagrams like figures 15.1 and 15.2 in the source showing those layers.
Exactly. And the cortex, being less dense, shows up as alternating dark and bright zones under oblique light on the slit lamp, just depending on how the light scatters.
So, to sum up its function.
It helps focus light onto the retina. And that transparency is everything, maintained by the super regular arrangement of fibers and the lack of organelles. Anything that increases absorption or scattering messes with that clarity.
Which leads us directly to cataract. What's
Yeah.
the basic definition from our source?
Simply put, a cataract is any opacity, any loss of transparency in the lens or its capsule. It can be developmental, meaning present from early life, or acquired later on.
And they behave differently.
Generally, yeah. Developmental ones are often partial and tend to be stationary. They don't worsen. Acquired ones usually progress over time, potentially involving the whole lens, although there are exceptions.
The source makes an interesting point about the word cataract itself causing anxiety.
It really does. Imagine telling someone they have a cataract when it's just a tiny stable spot not affecting their vision. It can be unnecessarily alarming. So often, especially for minor or early things, clinicians might prefer saying lens opacities and explaining the situation calmly, managing expectations.
Right, communication is key. What actually causes this loss of transparency? What's the underlying process, the etipathogenesis?
Transparency is lost when the lens components, capsule, proteins, fibers get damaged. Think trauma, toxins, changes in hydration, UV light. The opacity itself comes from degeneration of existing fibers, formation of abnormal ones, or even deposits of other materials. Fundamentally, it's about abnormalities in those lens proteins or disorganization of the fibers. The exact why can vary a lot. Any physical or chemical disruption to the delicate water and electrolyte balance or the protein structure can kick it off.
For example,
Well, abnormal fibers might form if the dividing cells malfunction, like in posterior subcapular types. You might see fibrous changes in complicated cataracts. Cell death, necrosis can cause focal spots like Glaucomflecken after acute glaucoma. Or abnormal substances can deposit from metabolic diseases or toxins like Fabry or Wilson disease.
the source emphasizes three key biochemical factors involved.
Yes, these are really central to understanding how it happens. First is hydration. This is big in early fast-forming cataracts. Fluid gets in, forms little pockets or lacunae, the tissue swells, that's intumescence, and it becomes opaque.
Now reverse.
Sometimes, yeah. The source mentions young diabetics whose early cataracts might clear up if their blood sugar is tightly controlled. It's due to osmotic shifts or changes in the capsule's permeability. It's really dramatic in traumatic cataracts. If the capsule breaks, the fibers swell up fast, leading to a soft cataract.
Okay, hydration is one. What's the second?
Denaturation of lens proteins. Those crystalline proteins can clump together, become insoluble, forming dense, irreversible opacities. This tends to happen more in younger lenses or the adult cortex, where metabolism is more active. The older, less active nucleus is less prone to this specific change.
And the third factor?
Slow sclerosis. This is the typical age-related hardening and degenerative change in the nucleus fibers. It's a gradual process leading to what's called a hard cataract.
So hydration, soft cataract, protein denaturation, dense opacity, sclerosis, hard cataract, roughly speaking. What things actually trigger these changes?
The source lists a whole host of factors, nicely summarized in tables 15.1 and 15.2. Age is the biggest one. As we age, the capsule gets less selective, insoluble proteins build up, and protective antioxidants decrease.
Okay.
Environment is huge too, especially sunlight, UVA, and UVB exposure is strongly linked, particularly why cataracts often appear earlier in the tropics. Severe dehydration from diarrhea is mentioned. Nutritional deficiencies like low vitamins A, C, E, or certain amino acids.
What about toxins or diseases?
Yeah, various toxic substances are implicated, naphthalene. Certain sugars if metabolism is off, some metals. Toxic byproducts from eye inflammation like cyclitis cause complicated cataracts. Cyanate from smoking or kidney failure causes protein changes. High blood sugar and diabetes leads to glycation. Systemic conditions like hypocalcemia disrupt ion balance. Certain medications, especially long-term steroids or specific eye drops. And physical factors, osmotic stress, trauma, radiant energy like heat or x-rays, it's a long list.
It really is. So when these changes start happening, what does the person actually experience? What are the symptoms?
They're entirely visual, as Table 15.3 details. The most common symptom is just blurring of vision, usually gradual, painless, progressive. That applies pretty much across the board. Sometimes, especially in kids, the first thing is someone else noticing a white spot in the pupil.
Mouse.
In early stages, vision might still be correctable with glasses, but a key clue is needing frequent prescription changes. The cataract is altering the lens's refractive power.
That's a subtle sign.
It is. Another classic, maybe less common, is uniocular polyopia, seeing double or triple out of one eye. Not regular double vision, but distortion within the lens. It's worse with a dilated pupil. Looking at lights, patients might say they see multiple moons at night, common with spoke-like cortical opacities.
Interesting. Any others?
Colored halos around lights can happen, again due to refractive irregularities, especially cortical. Change in color perception, nuclear cataracts absorb blue light, making reds look more intense, often noticed after surgery when colors seem vibrant again. Loss of contrast sensitivity is big, especially with posterior subcapsular types. Makes seeing subtle differences hard.
You mentioned glare issues.
Yes, especially with posterior subcapsular or cortical types. Difficulty in bright sunlight, feeling blinded by headlights. That's due to light scattering and the pupil constricting over a central opacity. And just a general reduction in visual field sensitivity can occur too.
How much does the location of the opacity matter?
Hugely. It depends on density and position. Peripheral opacities, like early senile cortical ones, might not bother central vision much for a while. In fact, bright light might improve vision because the small pupil blocks the periphery.
Okay.
But central opacities cause problems early. Vision is often better in dim light when the pupil widens, letting light around the central block. Posterior opacities, right near the eye's optical center, nodal point, cause disproportionate vision loss even if they look small.
That nodal point effect.
Exactly. And nuclear sclerosis, that hardening, increases the lens's refractive power, causing progressive myopia. That's the second sight phenomenon. Someone who needed reading glasses might suddenly be able to read without them again.
But it's temporary, right?
Right, until the whole lens gets too cloudy. In advanced cases, vision drops way down, maybe just light perception or hand movements. But the source stresses. Cataract alone never causes inaccurate light projection or no light perception. If that happens, something else is going on.
And always important in older folks to rule out other things like glaucoma or macular degeneration.
Absolutely critical. Cataract isn't the only game in town for vision loss.
Right. Let's dive into the specific types, starting with the most common, age-related or senile cataract.
Senile cataract is basically aging plus lifelong sun exposure, especially UV. Rare before 50 without other issues, almost universal in some form over 70. It's protein changes causing opacity, usually both eyes, but often uneven. Genetics plays a role, sometimes appearing earlier in generations, and that earlier onset in the tropics points strongly to UV.
And the source describes different forms.
Two main types. Cortical, which involves hydration and protein coagulation in the cortex. You see wedge-shaped spokes starting peripherally, often lower nasal, moving centrally, causes irregular refraction, maybe that polyopia, can become diffusely cloudy or white. If it swells a lot with water, it's intumescent, making the front chamber shallow. Mature means the whole cortex is opaque, no iris shadow.
And the other main type.
Nuclear or sclerotic, that's the central hardening. Cortex might be clear, starts maybe after 40, blurs distance more than near, causes that second sight myopia. The nucleus gets cloudy, can turn brown, or even black cataract brunescens or nigra. Progress is usually slow.
The source also mentions hypermature stages.
Yes, for cortical cataracts. Hypermature means the cortex breaks down, shrinks, becomes sort of pasty. Capsule thickens, the lens can become tremulous, phacodemesis, iris tremulous, iridodonesis, anterior chamber deepens, zonules might fail, causing dislocation.
Wow.
And Morganian is a specific type where the cortex liquefies completely and the dense nucleus sinks to the bottom, looks milky with a brown nucleus that moves with the head.
How fast do these progress?
Senile cortical varies a lot, can take years, might never fully mature. Faster progression, especially in younger patients, hints at complications like diabetes or inflammation, needs regular checks.
There's another cortical type mentioned, cupuliform.
Right, cupuliform, dense, plaque-like opacity just under the posterior capsule centrally. Hard to see sometimes with just an ophthalmoscope, but clear on slit lamp retroillumination. Because it's posterior and central near that nodal point, it causes significant visual disturbance even when small.
Slit lamp really is key then. Okay, moving on to cataracts caused by other eye diseases, complicated cataracts.
Exactly. These result from disturbed lens nutrition due to things like chronic inflammation, iridocyclitis, choroiditis, tumors, high myopia, retinal detachment, things like that. Anterior inflammation often causes rapid diffuse cortical opacity. Posterior inflammation or degeneration typically leads to that characteristic posterior subcapsular cortical opacity, starting axially.
What do they look like?
On slit lamp, they often have irregular borders, maybe look like breadcrumbs, and can have a polychromatic luster, sort of a rainbow sheen. Unlike developmental types, they aren't sharply defined. can stay put or progress. Vision gets hit early because of the central location. Surgical outcome depends heavily on controlling the underlying eye disease. If you see this type without an obvious cause, you have to hunt for subtle inflammation.
What about cataracts linked to diseases elsewhere in the body?
Several systemic links. Diabetic cataract is a big one. In adults, typical senile types just happen earlier and faster, likely due to glycation and oxidative stress. True diabetic cataract is rare, seen in young, acutely diabetic patients. Fluid vacuoles cause rapid myopia, then diffuse opacity that might even reverse with sugar control, can quickly become snowflake cataract-dense white subcapsular spots.
Others mention.
Parathyroid tetany from low calcium causes characteristic opacities, punctate subcapsular dots coalescing into flakes. Myotonic dystrophy has very typical early cataracts, fine dust, iridescent spots, maybe a Christmas tree pattern. Galactosemia, a congenital metabolic issue, causes cataract from galactitol buildup. Early dietary changes can prevent it. Down syndrome associated with punctate cataracts, and atopic cataract with severe skin disease.
And the miscellaneous causes.
Yeah.
Radiant energy.
Yes, heat, X-rays, gamma rays, neutrons. UV strongly implicated in senile cataract. Heat cataract infrared has a specific look, sharp posterior cortical disc, plus maybe exfoliation of the capsule layers. Seen in glass iron workers. Irradiation cataract, X-rays, etc., is direct damage to dividing cells, appears later at the posterior pole, resembles heat type but progresses faster, electric cataract after high voltage, and traumatic cataract from injury.
Let's switch gears to developmental cataracts, those present early on.
Right. Congenital or developing later in childhood. Huge variety here. Minor ones are super common. They often follow the lens's layered growth pattern, affecting the zone forming when some disturbance occurred. Causes are often unknown, but could be maternal malnutrition or infection like rubella, oxygen issues, calcium problems. Usually stationary, but can progress later, only matter visually if large and central.
What are the common forms described?
Punctate are the most common tiny ones, blue dot, sutural, central, pulverulenta, usually minor visual impact. Zonular cataracts are more significant, maybe half of visually important congenital cases. A specific zone around the fetal nucleus is cloudy, often with writers extending out, usually bilateral, can affect vision if large, linked to genetics or environmental factors like poor nutrition Vit D deficiency around birth.
Other types.
Fusiform, spindle-shaped. Discoid. Nuclear cataract can be minor, embryonal, or progressive and severe if linked to maternal rubella early in pregnancy. The virus damages the developing nucleus. Often comes with other major birth defects. Coronary cataracts appear around puberty. Peripheral, club-shaped opacities, usually hidden by the iris, don't affect vision. Anterior polar is a central white plaque, developmental or from corneal contact early on. Posterior polar related to remnants of fetal blood vessels.
Managing these in children sounds complex, especially regarding vision development.
It is. Evaluation is thorough history, exam, labs maybe, table 15.4. Check basic vision, eye health, rule out serious things like retinoblastoma, B scan if needed, measure eye length, A scan, refraction, assess density. Treatment hinges on visual impact. Minor ones might just be watched or managed with pupil dilation. Dense ones need surgery.
Timing seems crucial.
Absolutely critical. For some types, maybe wait until 1-2 years old. But if it's complete or causing squint nystagmus, surgery needs to be earlier. Unilateral congenital cataract needs surgery very early, first 6 weeks ideally, plus immediate contact lens fitting to prevent severe amblyopia. That 2 to 4 month window for fixation development is key.
What surgical techniques are used for kids?
Their lenses are soft, so usually aspiration through small incisions or lensectomy using a vitreous cutter. IOL implantation is possible. Decision depends on age, often 2 years. Unilateral versus bilateral, family situation. Foldable acrylics in the capsular bag are common. Power calculation aims for slight myopia in young kids to account for eye growth. Post-op is intense visual rehab, amblyopia therapy, monitoring complications like inflammation, glaucoma, PCO.
Beyond cloudiness, the source covers other lens abnormalities too. Shape and position.
Yes, often occur with other eye issues. Shape-size problems include coloboma, notch, bad zonules, PHPV, persistent hyperplastic primary vitreous, where fetal tissue persists, often with cataract and microphthalmos. Spheriphakia, microphakia, small round lens, maybe Weil-Marchesani syndrome. Lenticonus, conical bulge, usually posterior, linked to Alport syndrome.
And lens displacement. Ectopia lentis.
Right. Ectopia lentis, congenital subluxation, partial shift, or dislocation complete. Often upward, bilateral, hereditary signs. Visible displacement, maybe tremulous iris lens, iridodonesis, phacodonesis, deep front chamber, glaucoma risk. associated with Marfan syndrome, upward temporal displacement, and homocystinuria, downward nasal displacement, systemic issues. Problem is weak or broken zonules.
How is a copia lens treated?
Depends. Anterior dislocation causing glaucoma is an emergency removal. Subluxation might be managed optically if possible. Posterior dislocation without inflammation might be left alone. Removal is needed if vision is poor due to the displacement or resulting astigmatism.
Okay, we've covered lens structure, cataract formation, types, developmental issues, and other abnormalities. Let's pull back to overall cataract management.
The main takeaway: no medicine reverses cataracts once they're formed. If it's early hydration changes from a systemic issue, controlling the cause might help. But once proteins are denatured, it's done. Senile progression might halt. Refractive shifts offer temporary relief. Key is always check for and treat any underlying cause, like diabetes.
What about before modern surgery?
They used to wait until it was ripe or mature, managed with frequent glasses changes, adjusting lighting, bright for peripheral, dim for central opacities, maybe dark glasses or pupil dilating drops if the angle was safe.
But now?
Now, immature cataracts are routinely removed. The decision isn't about ripeness, it's entirely based on the patient's visual handicap. How much does it interfere with their life and needs? When that impact is significant, surgery is the only effective answer.
Patient-centered decision. What goes into surgical planning today?
A very thorough workup. General health check, especially for things like diabetes. Detailed eye exam, identify cataract type grade. LOCS system, maybe imaging. Assess nuclear hardness, crucial for phaco strategy.
And checking what's behind the cataract.
Absolutely vital if the view is blocked. Need to assess retinal and optic nerve function. Poor function means a guarded prognosis, patient needs to know. The source lists tests. Light projection accuracy, most important. Crude macular function tests, entopic phenomena, seeing own retinal vessels. B-scan ultrasound to image the back. Sometimes foveal ERG.
What about managing the eye itself before surgery?
Need a healthy front of the eye, no active infection, good pupil dilation. If it's a complicated cataract from inflammation, that inflammation must be quiet. Strict infection control. Treat any systemic or local infections, like tear sac issues, first. If the patient also has glaucoma, manage that strategically, maybe combine surgery or careful incision placement if they've had prior glaucoma surgery.
Let's talk surgical methods. The source contrasts old and new.
Right. ICCE intracapsular removed the whole lens plus capsule. Obsolete now due to high complications and can't put an IOL in the best spot, posterior chamber, only for rare total dislocations maybe.
Replaced by ECCE.
Yes, ECCE, extracapsular. Leaves the posterior capsule intact. Open the front capsule, capsulotomy, remove nucleus, wash out cortex. This allows stable posterior chamber IOL placement. Techniques under the ECCE umbrella include conventional large incision, SICS, manual small incision, lensectomy, phacoemulsification ultrasound, and femtosecond laser assisted.
Choice depends on the lens.
And age. Young soft lenses often aspirated lensectomized. Older hard nuclei need manual extraction or phaco. Good pupil dilation is essential for ECCE to see and remove everything. Local anesthesia, block or topical for phaco, is common, general for kids or anxious patients.
Key surgical principles.
Operating microscope, sterile prep. Incision placement type varies. Crucially, use OVDs, viscoelastics, to fill the front chamber, maintain space, protect the cornea.
Walk us through the main steps of modern ECC phaco.
Inject OVD. Create an opening in the anterior capsule, ideally a CCC, continuous curvilinear capsular hexus, a smooth round tear. Trypan blue dye helps see the capsule if it's white. Then hydrodissection fluid injected to separate cortex from capsule. Maybe hydrodelineation to separate the hard nucleus.
Then get the nucleus out.
In conventional ECCE, enlarge incision, manually express the nucleus. In SICS, smaller tunnel, manually remove fragment. In phaco, use the ultrasound tip through a small incision to break up, emulsify, and aspirate the nucleus pieces. Then use aspiration tools to remove the remaining soft cortex.
Then the IOL goes in.
Right. Implant the IOL ideally into the empty capsular bag. If complications, maybe the sulcus, space behind iris, or interior chamber. Aspirate remaining OVD. Conventional ECCE needs sutures. Phaco with foldable IOLs uses small, self-sealing incisions, often sutureless.
Surgery sounds slick, but complications can happen. What is the source list?
They categorize them by timing. Preoperative, anxiety issues, angle closure from dilation, anesthesia risks, bleeding, globe perforation. Intraoperative, poor prep, bleeding, patient movement, surgical errors, tissue damage, cornea, iris, capsule tear, zonual damage, lens dropping back, nucleus drop, severe bleeding, expulsive hemorrhage, IOL issues.
And afterwards?
Postoperative early days works. Iris prolapse, shallow flat chamber, leak, other causes. Retained lens bits, high pressure, severe inflammation, including TAS-toxic anterior segment syndrome, infection, endophthalmitis. Corneal swelling, wound bleeding, hyphema, astigmatism, retinal detachment, RD, worsening diabetic eye disease, wrong IOL power, refractive surprise.
Wow. And late complications.
Late Mustard years. Delayed infection, RD, macular swelling, CMO, PCO, posterior capsular opacification, capsule contraction, late IOL dislocation malposition, ongoing astigmatism, secondary glaucoma. It's a reminder of how delicate the eye is.
Okay. Lens out. IOL in ideally. That leads to optical rehabilitation. The eye is aphakic without a lens.
Exactly. Extremely hyperphobic unless they were very myopic before. Needs correction. Options. Thick distorting spectacles, contact lenses, handling issues, or an IOL. Today, IOL implantation is the standard part of the surgery itself, but even with a standard IOL, Retin glasses are needed because accommodation is lost.
Tell us more about IOLs.
They're the best solution. First one by Ridley in 1949. Modern ones have an optic, the lens part, and haptics, arms for positioning. Materials vary. PMMA, acrylics, hydrophobic, hydrophilic, silicone, can be rigid or foldable.
Lots of designs.
Many, based on location. Anterior chamber AC, posterior chamber, PC in the bag is best, or sulcus, scleral fixated. Shape size varies, haptics angled for proper fit. Optic shape can have square edges, helps reduce PCO, be biconvex, aspheric, better optics.
And different focusing abilities.
Standard are monofocal, need readers. Multifocal aim for near and distance. Accommodative try to mimic natural focusing. Toric correct astigmatism. These premium IOLs aim for less spectacle dependence. Most block UV. New tech includes adjustable IOLs.
Getting the power right sounds critical. How's that done?
Using formulas. SRK is a common family, need measurements. A-scan, ultrasound for axial length, keratometry for corneal curvature. Basic formula involves these, plus a lens constant, a constant. Newer formulas, SRKT, Holiday, Hoffer, are more sophisticated, especially for unusual eye lengths. Careful calculation is key to meeting patient visual goals. Aiming for perfect distance usually means needing readers. Complex calculations needed after other eye surgeries.
You mentioned PCO as a late complication. What exactly is that after cataract?
Posterior capsular opacification happens after E-certifico because the back capsule is left. Sometimes it stays clear, but often leftover lens epithelial cells from the anterior capsule migrate back and proliferate on the posterior capsule. They can form opaque Elschnig pearls or abortive fibers, creating a hazy membrane right in the visual axis. Inflammation can contribute too.
How common is it?
Varies. Higher rates in younger patients with older IOL materials like PMMA, lower with newer hydrophobic acrylics, especially with square edge designs, maybe 10–50% depending on factors, developing over 1 to 5 years.
How is PCO treated?
If it's visually significant, a Weige laser capsulotomy is done. The laser makes a small opening in the center of the cloudy posterior capsule, clearing the visual axis. Quick outpatient procedure. Very thick membranes, especially in kids, might need surgical removal, membranectomy.
Okay, that's an incredibly deep dive into the lens and cataract based on our source. Let's transition now to our second major topic, glaucoma.
Right, shifting focus from the lens clarity to the eye's pressure regulation system and the optic nerve. Glaucoma is another major cause of irreversible blindness, a chronic progressive optic neuropathy.
Neuropathy means nerve damage.
Exactly. Damage to the optic nerve, which connects the eye to the brain. This damage leads to characteristic patterns of vision loss, specifically peripheral vision loss initially. The main risk factor we can treat is elevated intraocular pressure, or IOP.
How does high pressure actually damage the nerve? What's the pathogenesis?
It's thought to be a mix of factors, mainly mechanical stress and vascular compromise, affecting the nerve fibers where they exit the eye. Yes, at the optic nerve head, specifically through a structure called the lamina cribriforme. Think of it as a sieve-like plate that the nerve fibers pass through. This is structurally the weakest point at the back of the eye.
Okay.
High IOP puts mechanical pressure on this lamina. It can directly compress and distort the nerve fibers and also disrupt blood flow and axoplasmic flow, the transport of essential nutrients along the nerve fibers. Over time, the lamina can actually bow backwards and its plates compact, further squeezing the nerve fiber.
Oh, the vascular part.
High IOP can also compromise the blood supply to the optic nerve head, especially if the local blood vessels can't autoregulate properly. Additionally, systemic factors like low blood pressure or vasospasm can reduce the perfusion pressure reaching the nerve. So it's potentially a double hit, mechanical damage and reduced blood flow.
Other factors mentioned.
Some eyes might be inherently more susceptible, maybe due to lamina structure, and that disruption of exoplasmic flow means fewer survival signals get to the nerve cells, leading to cell death or apoptosis. Nerve fiber loss often starts in specific areas, typically the superior and inferior poles of the disc, leading to corresponding arc-shaped visual field defects.
So diagnosis relies on spotting this nerve damage and the resulting vision loss.
Precisely. Key elements are examining the optic nerve head, ONH, mapping the visual field, VF, and measuring IOP. ONH changes often appear before the patient notices vision loss. We look at the cup-to-disc ratio, the size of the central depression relative to the whole nerve head. Normally, it's about 0.3.
What changes suggest glaucoma?
Things like asymmetry between the two eyes, a difference 0.2, localized thinning or notching of the neuroretinal rim, the healthy tissue around the cup, an enlarged cup, especially vertically, 0.5, pallor, small hemorrhages on the disc surface, characteristic changes in blood vessel patterns, and atrophy around the disc.
And the visual field defects.
These typically start in the mid-periphery, Bjorn's area, and match the nerve damage pattern. Common defects are paracentral scotomas, blind spots near center, a nasal step, loss respecting the horizontal midline nasally, and arcuate scotomas, arc-shaped defects curving from the blind spot. Advanced stages show large field loss, eventually leaving only a small central or temporal island of vision.
How are these field defects confirmed?
With automated perimetry, the source outlines criteria for significant loss based on statistical analysis, GHT, pattern deviation plots, PSDC, PSD values. Importantly, a defect needs to be repeatable on at least 2 reliable tests. Imaging tech like OCT, which measures nerve fiber layer thickness, is crucial for early or pre-parametric diagnosis.
What about IOP itself? What influences it normally?
It varies. There's a daily rhythm, often higher in the morning. It goes up when lying down, changes with breathing heartbeat. Exercise effects vary. Valsalva increases it. Drinking lots of fluid can raise it briefly. Even blinking or squeezing eyes shut causes spikes.
The source categorizes glaucoma types. What's the overview?
Broadly, primary adult, POAG, PACD, secondary caused by something else, and congenital developmental.
Let's start with the most common primary adult type, primary open-angle glaucoma, POAG.
Right. POAG is typically adult onset, bilateral but often asymmetric. The key feature is an open angle on gonioscopy, meaning the drainage structures are physically accessible. You see the characteristic ON8 VF damage, and IOP is usually 21 millimere Hg on repeat checks. Common in Caucasians Africans. Affects older adults mostly, runs in families. Specific genes like myocilin are linked to early onset forms, associated with diabetes, myopia.
Variants exist.
Yes. Normal tension glaucoma NTG has all the features of POAG, but IOP is consistently normal.
21.
Ocular hypertension, OHT, is the opposite. High IOP, but no nerve damage or field loss yet. POAG suspects have maybe suspicious-looking nerves, but normal IOP field.
If the angle is open, why is the pressure high in POH?
The problem is increased resistance to aqueous outflow within the drainage system itself, specifically in the trabecular meshwork near Schlemm's canal. It's partly an age-related change.
How does POA typically present?
It's famously asymptomatic, the silent thief of sight. Maybe nonspecific things like vague headaches, needing glasses changes, noticing a blind spot eventually, trouble with dark adaptation. The diagnosis comes from the signs: open angle, typical nerve changes, consistent field loss, and elevated IOP. Careful documentation over time is crucial.
Management sounds long-term.
Absolutely lifelong follow-up. Need good baseline data. Then determine a target pressure, an IOP level low enough to likely prevent further damage based on how bad the damage already is and other risk factors. Often aiming for 16-18 millimilli Hg.
Treatment starts with
Usually medical therapy eye drops, beta blockers, prostaglandin analogs, alpha agonists are common first choices. Add or switch meds as needed. If maximal medical therapy isn't enough, then consider laser trabeculoplasty, ALT or SLT, which tries to improve outflow through the meshwork, or surgery.
Okay, let's contrast that with primary angle closure disease, PTD.
PCD is different. Here, the angle itself is narrow or occludable, and the peripheral iris physically blocks the trabecular meshwork, causing IOP spikes. More common in Asian Eskimos, women slightly more for acute attacks. Risk factors are anatomical. Smaller eyes, shallow anterior chamber, anterior lens position. Lens growth with age worsens it.
How does the blockage happen?
Often relative pupillary block. Aqueous struggles to get from behind the iris through the pupil to the front. Pressure builds behind the iris, bowing it forward onto the meshwork. Things that cause mid-dilation, dim light, stress can trigger closure. Other mechanisms like plateau iris exist too. Gonioscopy is key to see if the angle is occludable. Can't see mesh work 180, 270 degrees without manipulation.
How is PCD classified?
Clinically, it's a spectrum. PASS, yes. Suspect. Occludable angle, no damage yet. PAC closure. Occludal angle plus signs of blockage, high IOP spikes, peripheral iris adhesions called synechia. May have intermittent symptoms, headache, blur, halos, PASS-EG, glaucoma. PAC criteria plus definite glaucomatous nerve damage, field loss, can be acute, sudden severe closure, very high IOP, pain, red eye, nausea, and emergency, or chronic gradual synechial closure, often asymptomatic until significant damage.
Treatment for angle closure.
First, lower the IOP medically. Drops, maybe pills or IV meds in acute attacks. Use pilocarpine drops to constrict the pupil, pulling the iris away from the angle. Once the pressure is controlled and the eye is quieter, the definitive treatment is laser peripheral iridotomy, LPI.
What does LPI do?
It creates a tiny hole in the peripheral iris. This allows aqueous to bypass the pupil, equalizing pressure between the posterior and anterior chambers, letting the iris fall back away from the angle. It's mandatory for all PASS-EG stages and usually done prophylactically on the fellow eye. Needs follow-up to ensure it worked and check for chronic pressure issues.
What about secondary glaucomas?
These are glaucomas caused by another identifiable condition, inflammation, trauma, tumors, medications like steroids, abnormal blood vessels, lens issues like pseudoexfoliation where material clogs the drain, or pigmentary glaucoma where iris pigment sheds. Treatment involves adjusting the underlying cause and controlling the IOP.
And pediatric glaucomas?
Present at birth or early childhood. Primary congenital glaucoma is due to abnormal development of the drainage angle itself, often genetic. Secondary can be from syndromes, injury, inflammation, cataract surgery. Often presents with classic signs like eye enlargement, ophthalmos, corneal clouding, tearing, light sensitivity. Management is primarily surgical, goniotomy, trabeculotomy, to open the drainage channels. Juvenile POA occurs later in childhood, young adulthood, often strongly genetic, mycilin gene again.
So managing any type of glaucoma involves
recognizing it's chronic, requires lifelong monitoring and often treatment. Patient education is vital. Regular checks of IOP, optic nerve appearance, and visual fields are needed to ensure the pressure is controlled well enough to stop progression.
When is surgery needed for glaucoma?
When medical laser therapy fails, if the patient can't use drops reliably, if pressure is very high initially, or sometimes as primary treatment. The goal of most glaucoma surgery is to create a new drainage pathway for the aqueous fluid.
Like trabeculectomy.
Trabeculectomy is the most common filtering surgery. It creates a channel from the anterior chamber under a partial thickness scleral flap out to a space under the conjunctiva, the bleb, bypassing the blocked natural drain. Scarring can cause it to fail, so anti-scarring agents, mitomycin C, 5-FU, are often used. For difficult cases, glaucoma drainage devices, tubes shunting fluid further back, are an option.
What's the overall prognosis?
Vision loss from glaucoma is irreversible, so early detection and treatment are key. If caught early and managed appropriately, progression can usually be slowed or halted, preserving useful vision. Prognosis depends on the type, severity at diagnosis, and adherence to treatment. Continuous monitoring is essential to detect any worsening and adjust treatment, maybe lowering the target pressure further.
We have certainly gone deep today, navigating the complexities of the lens and the eye's pressure system as laid out in this source material. From the lens fibers losing their nuclei for clarity, to the subtle ways cataracts develop and affect vision, through to the mechanical and vascular damage in glaucoma, and the array of treatments, it's been comprehensive.
Absolutely. By meticulously unpacking these specific source texts, the aim was to build that detailed, interconnected understanding, moving towards that professional-level mastery of this information you asked for.
It really highlights the delicate balance needed for sight and how problems cascade when things go wrong.
It does, and it makes you wonder, doesn't it? Given this intricate biology for vision and pressure control and all the factors we know influence it, what other hidden connections or processes within our bodies might be playing a role that we're still uncovering?
A fascinating question to ponder. This deep dive, focused squarely on your chosen source material, has hopefully equipped you with the insights you were seeking. Thanks for joining us.